So, hello, good evening, everyone. I'm Dr. Shantanu, and I'm here today to discuss some important questions that might come up in your PSC exams. So, this is a question-wise discussion. We'll discuss the answers. We'll discuss how can we remember this fact. One before we start, I would like to reiterate that, and I hope you all know, and you must have noticed that the PSC question paper, the pattern as of now is a little bit different from NEET. NEET has certainly changed its question type from a very objective type to a very subjective type. You'll have a lot of pictures also. You'll have a long question with long answers, multiple choices. Not multiple choices, but in the sense you'll have a long option is also very long. So you'll take some time to read it to understand the question. Well, in PSC exams, it is mostly objective and mostly factual. So that kind of difference you must have noticed, you guys must have noticed, and that's how we'll proceed. Okay. So let's try to make this easy for you guys. So the first question is again very, very objective, very, very easy also. Which one of the following is the most reliable method of age estimation in orthodontics? We all know that we do not rely on chronological ages in orthodontics because age estimation helps us to decide whether we can go for an orthopedic appliance, can we go for a myofunctional appliance, do we have to opt for nothing but a camouflage treatment, can we go for a surgical option? So all these factors I mean, the age estimation helps us decide these treatment plans. Okay. So the factors, there are many factors, right? But the question is very, very simple. They are not asking you the details. They are just asking on which method would you rely upon. So look at the third option, chronological age. I just said that we do not rely upon chronological age. That is the easiest thing to do. So that is out of question. Okay. Now dental age. Now you will find a patient who would have a molar erupted much more sooner than the I mean than the actual ideal age, right? Similarly, you'll have canine, or you might have a patient who would show tooth eruptions much later, or you might not. I mean, maybe there is a cyst or something, and that is why molar is not erupted, and you suddenly decide, according to dental age, oh, okay, the molar is not erupted. Patient is although 6 years old, 7 years old, chronological age says 6, but maybe the molar is missing. You just look into the mouth and see, okay, molar is not erupted as yet, and you decide upon that. Well, would that be right? The answer is no. So yeah, we do not rely upon dental age much again. But then you might say, okay, sir, we look at the IOPA and not just the clinical picture. You're absolutely correct. But then again, a IOPA with a tooth at a certain age would have many more factors behind it that might delay and might not impact the growth per se, the skeletal growth of that patient per se. Although dental is delayed, but skeletal growth might not be affected at all. So dental age is also out of the picture. The second one is quite close, which is peak height velocity. But you will understand that it is a very cumbersome procedure. You have to it is not a cross-sectional method of age estimation. I mean, it is a longitudinal uh, option, because then you'll have to uh, measure the height of the patient since many years, and then see the height velocity of the speed of the height increased, right? And then you decide upon that. So that is also out of the picture. So hand wrist radiograph is the answer. So just a quick recap on the hand wrist radiograph. We have various ossification centers and a sequence of epiphyseal maturation, which is a direct skeletal maturity indicator. We take a hand wrist radiograph and then decide upon that. Chronological and dental age are less likely correlated with skeletal growth spurts. That's absolutely true. Peak height velocity is helpful clinically, but hand wrist radiograph is much more precise. So this is telling you the reason. Okay, so I just thought that we might give you a summary table which would tell you just the basic things, because they might ask you about other hand wrist ways of hand wrist radiographs, about other authors, their years, what was the point that they were using. So the thing that we should remember is GP, which is Grelick and Pyle Atlas. So Atlas is basically a book with the collection of pictures, right? So they used to take up an atlas. They would have a hand-wrist radiograph, and then you would match your patient's hand-wrist radiograph to their hand-wrist radiograph, and based upon that, you decide upon the skeletal age of that patient. Similarly, Tanner Whitehouse, which is the Tanner Whitehouse 1, which came in 1962, then 2 in 1975, and then 3 in 2001. So assigns scores to each bone. Some of the score is the skeletal age. 20 bones of hands and wrist are included: radius, ulna, carpals, and phalanges. Fishman skeletal maturity index is the most commonly used. If you are going to mug up one skeletal maturity indicator, then I would suggest that you go for a Fishman skeletal maturity indicator. 1982, discrete ossification events. We have talked about this in detail in the previous videos. So I would ask you to go there if you really want to know in detail. So there are 11 indicators, which include adductor sesamoid, phalangeal, capping fusion, and radius fusion, right? Bjork and Helm, which was in 1967, correlates epiphyseal capping fusion with pubertal growth spurt. Epiphyses of radius, ulna, and phalanges are included. Causes of cleft lip and palate are placed in which grade of dental health component of the IRTN index? Okay, this is a question which is absolutely factual, requires a lot of mugging up. It's really boring, and most of the times we leave it. But I've seen this pattern in NEET also, and in various these PSC exams also, that you would have at least one question on indices. If they want to give you a question in that chapter, they'll give just one question on indices. Now that is a gamble. If you want to play it, you can, or you can just leave the question, because I understand not everybody of you would be able to mug it up, but I'll try to help, at least give you few pointers if you see that point, and if you're not confused, then at least you can take that answer. If you see a lot more points and you're confused, then you can always leave it, because it's always better to not go for a negative marking, right? Okay. So they're asking cleft lip, cleft palate are placed in which grade of dental health component of IOTN index. So what is IOTN index, first of all? So the answer is grade 5. But what is the IOTN index? IOTN DHC grade 5 is reserved for severely handicapped conditions, which is cleft, craniofacial anomalies that clearly require multidisciplinary care. Cleft lip, cleft palate, we all know, produces major functional aesthetic impairment and is categorized in the highest treatment need grade. So IOTN is index for orthodontic treatment need. So we basically understand simple English. So this index is basically classifying how important is orthodontic treatment for this particular patient. The higher the index, the more important it is to visit the orthodontist and get himself orthodontically corrected. Okay, so this index would have two things. One is DHC, one is AC. DHC is dental health component, the other is aesthetic component. Dental health component has 1 to 5 grades. Aesthetic component would have 10-point photo scale. So photo scale is again similar to Atlas. We'll discuss about that later. Okay. So this is the table which is giving you key examples and key traits. So grade 1, 2, 3, 4, and 5. So 1 would have no need, 2 would have little, 3 moderate, 4 great, and very great. So cleft lip, cleft palate, obviously you want the patient to visit the orthodontist. So it is always, I mean, it's logical to keep it on the highest grade. So grade 5 is the grade. Okay. I'll not go into the details of it. I would give you a simple, precise table at the end. Okay. Now look here on the left side, aesthetic component 1 to 10, 1 to 4. If your score is 1 to 4, it is done basically using photographs. So you match your photographs in the atlas with the patient's photograph, and then on the basis of that, you decide. So if your score is 1 to 4, there's little or no need. 5 to 7, borderline need. 8 to 10 is definite need. So 1 to 4, if you see here, so basically they are combining two categories of the treatment needs of the DHC. So if we say that 1 to 2 is no need, 2 to 4 is little need, so we can always say 1 to 4 is little or no need. Okay. Then 5, 6, 7, 3 for borderline need. Borderline need, obviously, moderate need is included. I mean, it is basically like moderate need. and 8 to 10, 8, 9, 10, 3 again for definite need. So first category has 4, then 3, then 3, right? Okay. So the quick exam, I mean, triggers that you should remember is that if you find this in the question, you can always go for grade 5. Nothing to be worried about. So that is a gamble. If you see it, then you might go for it. You might take that gamble. Okay. If you see in the question that the cleft lip, cleft palate is written, you can always take grade 5. Doesn't matter whatever things are given. It says mild cross bite, 1 to 2 mm of cross bite, displacement of 2 to 4 mm. No need to be confused. You just look at the highest grade, the thing which has the highest grade. For an example, cleft lip and palate. If it is there in the question, no need to think, go for grade 5. If the overjet is more than 9 mm, no need to think, go for grade 5. If there is reverse overjet, more than 3.5 mm, there is speech problem, there is trauma included, go for grade 5. If your overjet is given between 6 to 9, go for grade. You can always go for grade 4. 3.5 to 6, which is the prior one, and incompetent lips, grade 3. If the lips are competent, grade. Okay. You look for these pointers. If you're not able to mug up the entire IOTN, no need. Look for these pointers. Okay. Another index. Deliberately, I put this question here. Treatment priority index for recording the severity of the malocclusion was given by whom? The answer is Granger. It is a very boring factual question. If you remember it, good. Don't remember it, I don't have anything to blame you. The question is such that you might not remember it. Okay, but I want you to remember the things around it. So the TPI given by Granger, IOTN is something which was looking at the treatment need in the orthodontics. Whereas if you look at the treatment priority index, the concept is similar. Okay. So basically, it is providing a numerically severity score to prioritize treatment needs. Similar, very similar. Okay. But the things are different. Okay. So the way it divides is very, very different. So basically, what they are taking is the components here. So it is, I would say, much more standardized as compared to TN in the sense, it is easier for things, easier to remember. I mean, so look at this. I mean, overjet, overbite. These are the things that you consider as an orthodontist. Open bite, you see cross bite, a displacement or missing, irregularly placed teeth and missing teeth, right? These are the 5, 6 things that are important for you. So you know what overjet is, you already know what overbite is, you already know what is open bite, you already know what is cross bite, anterior posterior, similarly open bite. Displacement, crowding, spacing, whatever it is, missing tooth, agenesis or extraction. So basically they are giving scores from 0, which is normal. So if the overjet is normal, then you give 0. If overbite is normal, you give 0. Higher score, that means there's deep bite. Open bite, score by the of open bite. If there is 1 of open bite isn't normal. So you understand, even if there is 1 of open bite, then you have to give 1. If 2 of open bite, then 2. Similarly, cross bite again, presence and severity is scored. If it is present, then you give a score and then severity. So similarly, you keep on giving scores. Basically, displacement, it is also measured in and then same number of and the number of teeth involved, and that is how you score it. So ultimately, what the question will mostly have is that they will give you a total TPI score and they'll ask you what do you think about the treatment need. Okay, so the most important table is here at the bottom: 0 to 3, 4 to 6, 7 to 9, more than 10. Okay, 0 to 3 minor, 4 to 6 of course definitive, 7 to 9 and more than 10. So I want you to remember is that it is something like IOTN aesthetic component. Not that it is aesthetic, but the division is similar to aesthetic component. You understand? 1 to 10 ka scale. Here it is of course 0 to 10, 0 to 10. And there we had 3 divisions. Here we have 4 divisions: minor, definitive, severe, very severe. Okay. So 0 to 3 again, like 0, 1, 2, 3, there are 4 components, just like IOTN AC. 4, 5, 6, 3, then 7, 8, 9, again 3, and finally 10 and more than 10, it is very severe. So you don't have to remember two things. You just have to remember that this index is very similar to IoT and AC. Okay. Okay, now it is a much more, this is also a factual question, but this is something that you learn in various subjects. You learn it in dental anatomy, you learn it in human anatomy, you learn it in orthodontics also. So they're asking is the center of ossification for the mandible appears in the perichondral membrane lateral to Meckel's cartilage. So one fact they're giving, but they're asking you the time. Is it 10 weeks of gestation, 8 weeks of gestation, 6 weeks of gestation, or 4 weeks of gestation? The answer is 6 weeks of gestation. Okay, let's just try to recap the things around it. Mandibular ossification begins at a very early embryogenesis, classically around 6th week of Meckel's cartilage, 6th week of intrauterine life, lateral to the Meckel's cartilage. So what is the center of ossification lateral to Meckel cartilage? Type, it is intramembranous. Always remember. Guys, always remember that most of the mandible is not endochondral, it is intramembranous in ossification because it is not the Meckel's cartilage which gets ossified. If it had been the Meckel's cartilage which got ossified, then it would have been a endochondral. Chondral means cartilage, right? So endochondral ossification, but no, ossification is lateral to it, right? Beside it. So it is the Meckel cartilage is basically serving as a supportive structure lateral to which ossification is happening. So it is intramembranous type. 6th week of gestation. I'm sorry, you have to bug up. The exceptions. Okay, there are few exceptions in the matter. So it is mixed. So condylar cartilage, condyle is also endochondral, coronoid process, endochondral, posterior ramus, endochondral. Okay, these things are the these few are the exceptions for intramembranous ossification. Okay, when does the fusion of these halves happen? Well, the symphysis, fusion of the mandibular halves happen at symphysis or by 9th week. So this is what I was talking about. So the site is just mesial to, it is lateral to Meckel's cartilage. This is the Meckel's cartilage, the green thing that you see, it is the Meckel's cartilage. So this is the mandibular nerve which gets branched into lingual and the inferior alveolar branch. When there is a division of inferior alveolar branch into mental and incisive branch, that is where the initial site of ossification is. Okay, I want you to remember, and it is lateral to the Meckel's cartilage. Okay. So this is a gist of, I thought that it would really help you out if we can just give a gist of important dates which are really important, which you have to learn. 4th week, migration of NCC. 5th week, stomatodium is formed, which is primitive mouth. Maxillary and mandibular process appear. 6th week, center of ossification for the mandible, no confusion. 7th week, development of nasal pits, not that important. 7th to 8th week, upper lip formation, not that important. They might not ask you. 8th week, tongue initially high between palatal shelf and later falls down to elevate the shelves. 9th week, important fusion of two mandibular halves at the mandibular symphysis. 10th week, palatal shells elevate and begin to fuse. It is around 10th week. 12th week, completion of secondary palate fusion there. So it initiated in 10th week, completed by 12th week. 12th to 16th week, tooth buds of primary dentition form. 16th to 20th week, tooth germs progress to cap and bell stages. At birth, alveolar process present, tooth germs of permanent teeth begin with mineralization for the first molars and central incisors. Okay. Okay. Chances of true skeletal changes in the maxilla using a face mask is best before the age of 11 years, 10 years, 12 years, or 8 years. Okay, this has been answered many times, I feel. Now, remember, they are not just asking that when should we use face mask. They are saying, okay, that is okay. Face mask is okay. Very good. You gave it to the patient. When do you think are the best chances of true skeletal changes? So they are saying at what age you should give so that the changes are much more skeletal as compared to dental. Okay. So the hint is there in the question itself. Had they asked you best age, the age before which you can give face mask, the answer would have been different. But especially when they are emphasizing true skeletal changes in maxilla, when should we give, before what age? Of course, they are hinting towards a lower age, right? Otherwise, why would they ask? So This is the line directly taken. Okay, maxillary protraction produces from profit. The most skeletal change when begun early, ideally before the age of 8, because sutures are still responsive after this age. Dental and alveolar effects dominate. Okay. So what is the background? Orthopedic appliances like face mask depend on sutural adaptability. Circummaxillary sutures, which are present around the maxilla, are most active in early childhood. After 8 to 9 years, skeletal response decreases and more dental tapping is observed. So the memory aid would be before 8, face mask is great. After 8, it just compensates. So there is dental compensation also. Okay. Opening of bite with anterior bite plane in the correction of deep bite occurs due to, is it due to intrusion of the lower anteriors? Is the deep bite correcting because of that? Is it due to eruption of the posterior teeth? Is it due to eruption of the anterior teeth or none of the above? Okay. Eruption of the anterior teeth is out of question, because if there is eruption of anterior teeth, obviously the deep bite will increase, and we are talking about correction of deep bite. So that option is out of question. The only two real options that you have is it intrusion of the lower anteriors or is it the eruption of the posterior teeth? Because if you are giving anterior bite plane, then the lower anteriors, mind you, would strike on the upper bite plane, which is there in the palate. This would cause some intrusive effects. This would cause correction of deep bite. But what are they saying? Opening of bite with the anterior bite plane in correction of occurs due to. Now, when they are asking this question, they have this in mind that of course there is some part of it. But what they are majorly asking, what is the major part which causes the correction of deep bite? What do you think? Is intrusion a easier movement to do? I mean, imagine a tooth which is highly mineralized. You are pushing it against bone, which is again very mineralized. Two mineralized substances against each other, or do you think supra eruption is the easier thing to do? I mean, supra eruption. I mean, if there was no opposing teeth, you send the patient home with extraction of, for an example, 2/6, and the patient forgets to come to you for an year. After a year, he comes to you. Do you see supra eruption of 4/6? I mean 3/6. Of course, you see that. Okay, so supra eruption does happen. You know that the teeth stop erupting when they get in contact with the opposing teeth. Once that opposing teeth contact is missing, they'll start erupting again and again. Of course, you're putting wires, so that'll help in that. You might give elastic, that'll also help. Okay, so I want you to understand this concept. Of course, intrusion is a very difficult movement to do. Extrusion is comparatively easier. So the answer is eruption. Well, you see, this is how an anterior bite plane might look. And you see that there's a gap between the posterior teeth. What this will allow is the posteriors to erupt. Now, when you remove this anterior bite plane, the posteriors have erupted. Now, the occlusion is settled here. So obviously, the mandible will not rotate further, will not further rotate, right? Getting, you understand, if this rotates, for an example, I mean, if this rotates, mandible rotates further inside of the maxilla, then there's deep bite. If occlusion is stopped here because of the eruption of the posteriors, it won't go further inside, and hence deep bite is corrected. So there's little true lower incisor intrusion with simple anterior bite planes. The clinical effect is mostly from posterior eruption. So just anterior bite plane is not enough. You need to put TADs and everything. And then also true intrusion is very difficult to achieve. Okay, remember that. Okay, which of the following cephalometric values expresses the variation in the vertical height of the face? Which of the following cephalometric values gives variation in vertical height of the face? Is it IMPA? Is it FMIA? Is it ANB? This is the easiest question that you can get. Of course, first of all, get IMPA out, get FMIA out, because they are talking about incisor, lower incisor. So these things are out of the bucket of true answers, right? Now, A and B, we all know this gives us the sagittal position, not the vertical position. So this option is also out of the park. The only option that is left with you is FMA. Now, what is FMA? We understand that FMA is required in Tweed's analysis. In Tweeds, we are considering three angulations basically: FMA, IMPA, and FMIA. Okay. So FMA is the angulation between the Frankfurt horizontal plane and the mandibular plane for the tweets. So tweets, I hope you remember, we had told you in the previous videos, T for tweets, T for tangent. So it is tangent to the lower border of the mandible. The angulation between the two tells us the vertical profile. Of course, if the angle is increased, you see that this side increases. For an example, if this was here, so the length of the face has increased, so the vertical height is increased. If the FMA is less, just like this here, so you understand that the vertical height is reduced. The mandible is rotated. Okay. Okay. Early mesial shift of the first permanent molar compensates for incisor liability, corrects the developing midline diastema, utilizes anthropoid space, depends upon the leeway space. Okay, compensates for incisor liability. How would it compensate for incisor liability? Incisor liability is that the uh, primary incisors, their dimension is less as, especially the mesiodistal dimension is less as compared to permanent incisors. So basically, permanent incisors do not have that much space to erupt. That is a liability on them. So that is incisor liability. If molars shift further mesially, then incisors have much more less space. So how would it compensate? Okay, this option is out of the par. Corrects developing midline diastema. Okay, we all know that the developing midline diastema is corrected by the eruption of canine and not the first molar. Okay, so that is also out of the question. Depends upon the leeway space or anthroid space. Now, this is a basic confusing option. So this is basically this option. These two options are given to confuse you, right? Whether to go for leeway space or do we go for anthroid spaces, arthropoid spaces. Anthropoid spaces are basically simian spaces. Now we understand where is it located. We understand that it's located mesial to the upper canine and distal to the lower canine. And they are talking about early mesial shift of first permanent molar. Now, this is also something that we have discussed many times. Remember the logic. Now, leeway space is basically the space. It is the difference in the mesodistal dimension of CDE and their successors, canine, premolar, and second premolar. So obviously, we know that premolar canines erupt in the second transitional stage, much later than the eruption of first molar, much later. So how can early mesial shift of first permanent molar be utilizing the leeway space when the successors have not yet erupted, which would provide the leeway space? Of course. See, the only option left is anthropoid space, which is the simian spaces. Okay. Primate space, simian space, anthropoid space is just one and the same thing. Okay. So they utilize the space and the molar shift forward from flush terminal plane to class one, I wouldn't say malocclusion, class one relation in the molar, and hence it is very important. Okay. So the easy way to remember it is, if you don't want to understand the logic, or you're not able to understand, or you're not able to remember at that point of time, the very simple thing is do always remember late leeway. So L for late, L for leeway, early for primate. Okay. So primates came earlier than us, then they are. So that is a space which is utilized earlier. Leeway is always late. Okay. The personality considered as a forerunner of rapid maxillary expander is, so basically they're asking you who was the first person to develop rapid maxillary expansion. So that person was Emerson C. Angle. So angles have always been, the first ones, right? So he was the first person in 1860, regarded as the originator of RME. His case reports and Jack Screw helped has to, popularize his methods, and hence it is very important. So it was a very historical question, just for your information. Which among the following techniques cannot enhance the root or rate of tooth movement? Okay, there are few techniques which are utilized in orthodontics. See, the major drawback of orthodontics is that it takes a long time. Okay, so there are a few techniques which are utilized by the orthodontist to accelerate the tooth movement. Okay, there are various techniques. So what they're asking you right now is, which of them is not a technique which is utilized for this? Okay, so, well, I hope you know We won't go much into the details of it, but I just want you to remember that these techniques are vibrations, uh, laser therapy, low level laser therapy, LLT, and ultrasound. Okay, ultrasonic frequency. Okay. So heat is never used. Okay, heating doesn't help. You might think, okay, if we heat, then the blood circulation would increase, and then the inflammation would be maybe somehow affected and help in tooth movement. I'm so sorry, that's never the case. Okay, so heat is never utilized for accelerating tooth movement. Okay. I just want you to remember that vibration is there, low level laser therapy is there, activators, these vibrators are utilized. Heating the alveolus or the tooth doesn't help. Okay. Okay. Again, a factual question. Genetic theory of growth was put forward by Brody in 1941. Okay. So Brody in 1941 formulated the genetic theory, asserting that genes provide primary control of the craniofacial growth, which is intrinsic genetic control point of view. Intrinsic means that within the cell it lies, right? For each cell, the amount of growth which is decided is present inside the cell only. So that is why intrinsic viewpoint. Okay. Yeah. So it was very different from the sutural or functional matrix theory. I don't want to pressurize you to remember all the names, and that is why we are not discussing all the options. But if you remember the names, that would be good. Good for some names are very easy to remember, like suture and suture. So sutural theory was given by Suture, so that is how you remember. So I want you to develop something like that. Okay. Who is known for the father of computerized orthodontics and who gave servosystem theory of growth in 1980s? Okay, the father of computerized orthodontics is R.M. Ricketts, and the servosystem theory, I hope you remember, Petrovic and Stutzman. Okay. Okay. So Ricketts basically is the pioneer who developed this computer, who got computers into orthodontics a lot. So he gave something called visual treatment objective. What happens is, for an example, you are confused with a patient. A patient is has come to you with for an example, class 2 molar, and you need to decide whether to go for a digitalization or upper premolar extractions, upper 4 extractions, right? Now, what this would help you do is this would you do the extraction on the little ceph here on the computer, and then it would utilize this Ricketts visual treatment objective and give you the approximate facial profile. I mean, how the patient would look after digitalization and after extraction. So this will help you decide what needs to be done. If the facial profile is much more better in extraction cases, then you can always go for extraction. And if it is better in digitalization case, then you can always go for digitalization. Okay. So Ricketts for records and computers. Petrovic Stutzman described servo system theory. The background was that the growth of the mandible is adjusted by the functional need, which is the occlusion. So when the occlusion is disturbed, a feedback signal is sent, and that causes growth and various other things like. So it runs like a feedback loop. The body takes the feedback from the occlusion. So it was different from Moss functional matrix and Brody's genetic theory. And this was entirely different. It was very difficult to understand, I must say that. But yes, no need to go into the details much as for the PSC exams, they usually do not ask much into details. It is mostly shallow and very factual. Okay. Absolute anchorage in orthodontics is derived from this is a very easy question. Late non-palatal arch, transpalatal arch, lingual arch, they are all relying upon the tooth, right? And tooth can move. So this is not absolute anchorage, can never be absolute anchorage. Absolute anchorage is always skeletal in nature. So temporary anchorage device is screwed into the bone, and that is why they are absolute anchorage. They do not move at all until unless they fail, of course. Okay, again, factual question. E.H. Angle introduced his classification of malocclusion in which year? It was 1899. This is something that they have been asked, that has been asked previously, and that is why it is included in this. video so that you remember. Okay, so it was in 19th century, 1899, which became the foundational scheme for orthodontic diagnosis. Most important synchondrosis of growth modification is, okay, again, very commonly asked, sphenoectomoidal, spheno-occipital, intersphenoidal, intermaxillary. So what are synchondroses? I want you to remember what synchondroses are. So growth of the cranial base occurs at synchondrosis by the surface remodeling. A synchondrosis is similar to two-sided epiphyseal plate with proliferating cartilage cells in the center, and mature cartilage cells, where mature cartilage cells and ossification occur in both directions away from the center. Okay. So I want you to remember this diagram and these four synchondroses: spheno-occipital, spheno-ethmoidal, intra-occipital, and intersphenoidal. So so the most important one is spheno-occipital synchondrosis between sphenoid and occipital bone, as the name suggests, and which is the major site for anteroposterior cranial base lengthening. Most important, remains active till late at onset. Okay. Okay, so here is the confusion. So it is active and it does not fuse till 16 to 18 years. Okay. Whereas sphenoectomoidal, which is present between sphenoid bone and ethmoidal bone is in the front, sphenoid bone is here. So this is sphenoethmoidal that fuses around 7 years of age during early childhood. Intraoccipital found between basioccipital and exoccipital parts, fuse relatively around 3 to 5 years, and intersphenoidal, this is intersphenoidal. It fuses very early at birth or in utero. Okay, so sphenoethmoidal is a synchondrosis which is utilized for the anteroposterior growth in the early ages, especially for the maxillary part. Okay. Till this fuses, the maxilla is growing forward because this is this maxillary component is opposite to the anterior cranial base, and this is basically causing the lengthening of the this synchondrosis is basically causing the lengthening of the anterior cranial base. So according to that principle, the counter principle, the maxilla, since it is just opposite to the anterior cranial base, till the anterior cranial base goes, the maxilla will grow. So, and hence we always talk about getting the maxillary growth as early as possible, right? Okay. So the question is, which is the most important synchronosis for the growth modification? Well, we can always go for sphenoectomoidal. I'm so sorry. I'm so sorry. Okay. So we can always go for sphenoectomoidal if they are talking about the anterior part or the maxilla is given. For this, the answer that they gave was sphenoethmoidal, so I'm taking that into consideration. Okay. Okay, moment of force. Moment of force is something which is very basic for any orthodontic student. And it is a basic concept which has been greatly understood uh, for the physics students also. We understand what moment is. So moment is the force into times the distance from the center of the rotation, okay, where the force is applied. So for an example, look at the diagram. A force is applied. Well, it would create a moment because it is being applied away from the center of the resistance. Okay. So the tooth rotates and there is center of the rotation. Okay. So the distance between the center of the rotation and the force applied is basically becomes D. So for an example, force applied is 50 grams, then the moment generated is 50 into the distance between the center of the rotation to the force applied, which is 10 mm in this case. So the total moment gets out to be 500 grams per mm. Okay. So as I said, the definition moment of force, moment is equal to force into perpendicular lever arm. So it is used to describe both rotation and tooth movement. Now the order bends, third order bend, first order bend, second order bend. So the question is about third order bend. Is it in-out bend? Is it tip back bend? Is it docking bend or anti-rotation bends? Okay, look at this. So the first order bend is in-out bend when we are trying to get a tooth out or in. For in this case, like a step out bend has been given in both the teeth here in the A diagram. So this is a in-out bend and hence a first order bend. Second order bend is tipping, like here, look at this B. This would cause mesial crown tipping. So mesial tipping of the teeth. This kind of wire arrangement. Why? Why? Because the distal is down and mesial is up. For this, I consider this as mesial. Okay, so this would call mesial tipping. This is a second order bend. Third order bend is always about torquing. So this was a bracket slot. The wire would go straight in, but what you did was you give a bend in the wire so that the wire gets twisted and is forcefully inserted into the bracket and would cause a rotation of the bracket, which is around attached to the teeth, and hence rotation of the teeth in the buccolingual direction, and which is what we call torquing. Okay. Another question is seventh key of occlusion. What is the seventh key of normal occlusion? We have discussed this many, many times. Is it molar relation, palatal plane, crown angulation, inclination, or Bolton's ratio? The uh, the the six keys of occlusion. First, we should know what are the six keys of occlusion. We have discussed it many times. Molar interarch relationship is first key. Mesodistal crown angulation is the second key. Labialingual crown inclination is the third key. Absence of rotations, tight proximal contact, and curve of spine. Now, this second mesodistal crown inclination tip is also second order bend. Labialingual crown inclination or torque is also third order bend. So they are third in number, third order bend. So even if you remember one of the thing, you'll remember the other thing, I hope. Okay. So these six keys were important to achieve ideal occlusion, but later it was discovered that despite having all six keys, the ideal occlusion was not achieved, which was later discovered by Dr. Wayne Bolton, who and by which Bolton's ratio came into play. It is a ratio which between the mesodistal tooth size of maxillary and mandibular arches, teeth of maxillary and mandibular arches, and it is ideal for ideal intercuspation, okay, and aesthetics. So always remember, this is the seventh key given by Dr. Wayne Bolton. Anterior ratio is 77.2%, overall ratio 91.3%. Why this is the case, we have already discussed before also, but I'll again like to reiterate and repeat that always remember that as compared to upper, your lower teeth are much, much smaller. So if you take the ratio of the mesodistal width of upper and lower, you will never reach 1, right? If the answer was 1, their mesodistal width would be similar. So when they are talking about the anterior 6 from canine to canine, we know that lower teeth will be much, much farther from 1. So when we are talking about fraction, it is 1. And when we are talking about percentage, it is multiplied to 100. So it would be away from 100. So it is 77.2. When all the teeth are included, we understand that posterior teeth are broader, especially the molar is broader in lowers. And hence the anterior, I would say, the higher position achieved by the maxilla in the anterior region is somewhat negated. So we reach closer to 1. So that is why 91.3. So I just want you to remember 77.2 and 91.3 and just understand the logic to get the answer for anterior, which is 77.2, and posterior for 91.3. Okay, this is the next question which is going to come in, and anterior Bolton's ratio, it is 77.2 or 91.3. The answer here is wrong. I'm so sorry. In the PPT, the answer is 77.2. Okay. Okay, so anterior 6 is 77.2, not 91.3. If an anterior bite is not crossbite is not corrected with a tongue blade therapy, then the appliance used is inclined plane, Z spring, fixed appliance, ice cream spatula. Ice cream spatula is nothing but tongue blade, similar to tongue blade. So yeah, that is out of the question. Fixed appliance, well, we have not tried everything as of now. So you have two real options, which is inclined plane or Z spring. So Z spring, they are not saying along with posterior bite plane. Z spring, anterior crossbite will only be corrected if the two teeth are disengaged, right? So if until unless you disengage the anterior teeth, whatever force you apply, this upper teeth will not come out. So they are only saying Z spring with Hollies, with posterior bite plane, nothing is given. So that option is also out of the picture. The only real option that you have is inclined plane, which is Catlin's. They are talking about Catlin's appliance. So yeah. So this is a fixed appliance through which we can also correct anterior cross bite, but bite has to be raised. This is tongue blade therapy. Okay. And here, this is Catalan's appliance, which is an inclined plane, which is given on the lower teeth, which would push the upper teeth out and there is an angulation of the slope at 45 degrees. Okay. What is a pendulum appliance? Is it used to disclose maxillary molars? Is it used to disclose mandibular molar, maxillary canine, mandibular canine? Okay, disclosation, we can only talk about one thing, which is molar. The only option, the confusing option is A and B. Is it maxillary molar or a mandibular molar? I hope you all remember that pendulum is installed in the maxilla and hence maxillary molar is disclosed with this. Okay, this is how it looks. This is the palate. This is the palatal part. Okay, and this is the pendulum arm. Okay, this lies straight when it is inactive, and this is forcefully twisted and engaged into the molar, so it pushes the molar in a circular, more of a circular motion, but it is not completely achieved. So yeah, distalization is achieved. Okay, but the motion is like a pendulum, and that is why the name pendulum appliance. It is used in for the correction of class 2. Of course, if you dislize molar from class 2 position, it will come into class 1. It will only come if a maxillary molar is disliced. So that is also a hint that maxillary molar is being disliced. Okay, so there are different types of pendulum. The original conventional pendulum is also known as Hilger's pendulum. Okay, then there is Pendex appliance, which utilizes expansion screw, K-loop pendulum, which minimizes the distal tipping and provide more of a bodily movement. Okay, and mini implant supported pendulum, which is TAT supported, gives absolute anchorage. Okay, always remember that with distalization, whenever you are pushing the posterior teeth back, the anterior teeth will have action reactionary forces and would cause proclination of the anteriors, right? So what we do is we install TAT so that this effect of tooth support, which is seen with the conventional pendulum, is negated. Okay. Expansion rate in rapid expansion appliance and which is the appliance used. So this is a very simple question. We all know that whenever rapid expansion is being talked about, it is 0.5 to 1 mm per day. Whenever slow expansion is talked about, it is 0.5 to 1 mm per week. So that is the difference between slow and rapid maxillary expansion. The appliance which is used is W arch, quad helix. Face mask is not even used for expansion, so get that out of the picture. W arch and quad helix are used for expansion, but these are the appliances which causes slow expansion. So higher X screw is the answer. Easy question. Eruption path of the posterior maxillary permanent teeth is directed downward and mesial, downward and buccal, downward and labial, downward and distal. Okay. The eruption path of the posterior mandibular teeth is downward mesial or downward buccal, downward labial or distal. Okay. So they are talking about eruption paths. This is something that you have learned in first year as a part of Wheeler's book that you used to study. Okay. So I have compiled the maxillary mandibular uh, movement of eruption. So whenever we are talking about central incisor, it's gonna go occlusal and slightly labial. Lateral incisor is occlusal and slightly labial. Canine is downward, forward, and labial. This is the direction of the movement. Okay. So first molar, second premolar, and first molar, occlusal buccal, downward, forward, and buccal. So the answer is gonna be downward and buccal. There is no forward option which is given. So we'll go for downward and buccal. Okay. Thumb sucking is normal up to what age? So thumb sucking is normal up to 4 years of age. Okay. It is a natural self-soothing reflex. Up until 4 years, or everything is good. Beyond 4 years, it is a habit that has to be destroyed. Okay. Again, a time-based factual question. Fetus develops infantile swallow and suckling by the age of 32 weeks in intrauterine life. Okay, this is something that I missed in that table, so do remember this. Okay, there are some things that you have to purely mug up. There's no other option. Okay. In an infant, the gum pad is separated from the palate by gingival groove, dental groove, lateral sulcus, transverse groove. Okay, this is development of dentition question. I want you to remember this diagram. Okay, this is incisive papilla. This is the transfer grooves that you see here. Here, there is lateral sulcus, then there's dental groove, and finally a gingival groove. Okay, so what they're asking is gum pad is separated from palate by, the answer is gingival groove. So gingival groove is the groove this is the groove, separates the infant's gum pad from the palate. Okay, this is the palate. You see yellow in color and pink is gum pad. So this is the groove which they're talking about. What are the other grooves? Gingival grooves I've already told. Dental groove separates the labiolingual portion from the lingual portion, labiobuccal portion from the lingual portion of the gum pad. Okay, so this is the dental groove. Here it is all buccal. Beyond lingual to this is all lingual. Okay, transverse groove, each divide the gum pads into 10 segments. Okay, 1, 2, 3, 4, 5. Okay, 5 here, 5 on the right and left, total 10. So it divides into different sections for each tooth. Okay, that is transverse groove. What is lateral sulcus then? It is a specific transverse groove which is located in the developing canine and first deciduous molar. So basically dividing anterior and the posterior regions, which is the most important factor in habits. So there are basically three factors which are involved. One is frequency, one is intensity, and other is duration. So I want you to remember FDI, foreign direct investment. This is something that our government does a lot. So FDI, foreign direct investment, frequency, duration, and intensity. Okay. So these are the three important parts of habit. Frequency, how often the habit is performed, duration, the length of the time it is performed, intensity in the amount of force which is exerted by the habit. Okay. So what do we require? That at least 6 hours per day of uh, this habit is required to cause any other effect. Okay. So frequency and duration are the most important things. Okay. Okay. Which one is a sign of thumb sucking habit? Is it deep bite, concave profile, convex profile, narrow mandibular arch? Okay. This is something that we had confused last time. See, always remember this kind of question, you can always use the elimination method. We understand that whenever the patient is sucking thumb, the tongue is placed in the mandibular arch. Since tongue is a muscle and is placed in the mandibular arch, is pushed away from maxilla, pushed into mandible, it will cause expansion of mandibular arch and not narrow mandibular arch. So this question is out of the park. Now deep bite. We understand that thumb sucking causes open bite. So how can it be deep bite? So that is also out of the park. The only two real options are left, which are left is concave profile and convex profile. We understand that whenever the patient is sucking thumb, he is basically pushing the upper teeth, front teeth forward, lower teeth backward. So this would kind of give a convex profile. Okay. So that is why the answer is convex profile. Look at this picture. Okay. The the premaxillary part goes forward, the mandible is pushed backward. So a convex profile develops till 3 to 4 years. It is normal. Beyond that, it's a habit that we have to get rid of. Increased overjet, open bite, and convex profile is usually seen. Okay, one thing I just wanted to clear the picture. I think that we left it like unclear and little confusing. So spheno-occipital synchondrosis is a synchondrosis which remains active till late adolescence. So it is very, very important. But the question says which important synchondrosis is used for growth modification by us. So growth modification is done only in early ages. We are not utilizing growth modification in 15, 16 years of age. We are using myofunctional appliance, not utilizing anything related to the cranial vault. We are using the mandible, okay, and the condylar cartilage. So nothing to do with the synchondrosis in the myofunctional appliance. So the answer would be sphenoethmoidal, okay? Okay. I think we have covered most of the questions. I want you to understand the logic. Take screenshots wherever necessary. That's okay. And try to understand each and every question and eliminate answers with the help of English and logic, because you have a lot to mug up. There are other subjects also. So I hope you gained a lot with this video. Thank you so much.